Greetings, and I muted out. We are we are live, back. Welcome to this latest episode of Masters of Health. We'll wait for people to filter in, but in the meantime, we'll talk about our latest guest next to me. Well, virtually next to me, Adjoa, Miss Adjoa. We are meeting from across the nation. What is it? Is it like 3,000? I'm so bad with that. 3,000 or 5,000 between the coast?
You know what? I'm not really clear myself because I always get that confused when I think of getting into the South. And I'm in Georgia and Texas, and then I'm like, okay, well, how much further? Because you're on the East Coast, right?
Yeah.
Yeah. So don't give me the tell. I won't tell no tales. How about that?
Okay, so however many miles away, however many miles apart we are. So we are joined by our latest guest, Miss Adjoa Jones, who is in the public health field. So as always, this show is about people who are in the public health field. Some of them have MPHs, some don't, but the whole point is that their career either is immersed or touches the fringes of public health so that we can give those who are public health students, graduates, or just interested in what it is, a glimpse into what happens in that world. So without further ado, I'm going to ask Adjoa to explain a little about what she does at the LA County Department of Public Health.
Well, thank you first for inviting me to be here. I'm really appreciative and just glad to be a part of the show and glad to really tap in and give some input to the public health community as well as to your community of those who are interested in getting into the field of public health, especially those with their master's in public health and their doctorate in public health. But currently what I'm doing with LA County is I am the visionary and co-lead for the, visionary of the African American Infant and Maternal Mortality Community Action Team. I'm the co-lead of the South LA South Bay AAIMM CAT. That's our acronym for it. But I'm also with LA County, the AIMM Outreach and Engagement Director. So my work is to provide oversight to the community action teams and then also provide, input and support and work with my other colleagues on the entire AIMM initiative. And so what we're doing, basically, the goal of that is to save Black moms and babies, to interrupt the incidence of morbidity and mortality for Black women and infants. We have, for far too long, had the highest rates of mortality and morbidity. And I wanted to see that we have some significant changes within our city, county, state. Mm-hmm. And so I got involved in that because when I was in my undergraduate at Cal State Dominguez, and I was getting my bachelor's in health science, healthcare administration, I was working as a student professional worker with the county with the immunization program. Mm-hmm. And so while there was a partnership with the hospital to create some mobile immunization clinics. So that was, eons ago. I'm not going to tell you all, my age on here, but basically it was a couple decades ago. At any rate, while there, I met this amazing nurse who was a public health nurse, and she saw my work and said, hey, we're about to start this Black Infant Health Program. It is the first in the county. LA County was getting funds from the state. And we want you to be a community health worker there. And then once you graduate, we'll see where that goes. So I started off as the first community health worker for Great Beginnings for Black babies. And under the umbrella for that one was Inglewood Healthy Moms and Babies. And at the time then, our focus was on getting women into early prenatal care to stop the incidence, same thing of low birth weight or preterm babies. But really and truly, a lot of the focus was on women and what they were or were not doing, right? They were coming in late in their trimester. At that time, we were having the fallout of drugs, still the war on drugs and the fallout of that in our communities. They were heavily populated with crack cocaine. And so we were really looking at what Black women weren't doing, or we were doing a lot of victim blaming and shaming then. I mean, we could go into so much that has happened then. And so not long after that, I graduated with my bachelor's in health science, and they offered me the position, or to apply for the position, as a perinatal health educator. And so I became the perinatal health educator and used to work. Then we had like a kind of one-stop shop. You met the community health worker, they introduced you to the program. You would meet with me as to go through a like 8-part series of sessions around perinatal health, so like the whole labor and delivery process, pre and post. And then you would meet with the public health nurse, and that public health nurse would case manage you throughout the course of your pregnancy.
Okay.
So the Black Infant Health Program is still going on. But the reason why I wanted us to create a community action team was, one, I was on a project called Whole Person Care. Prior to me coming back to the Department of Public Health, I was with Department of Health Services for a few years. And so with Whole Person Care was a pilot project from the state to look at various issues of focus. So my issue, that because of my background in reproductive health and with Black infant health and maternal and infant health, I was my team lead for our regional collaboration team. The title was Associate Director of Regional Collaboration, and I was serving the South Los Angeles area. And so we had high rates of infant mortality there as well. Our current public health director, Dr. Barbara Ferrer, has started the Center for Health Equity, was coming out of the public health department. And in there, they were focused on infant mortality. And so the work was to combine both, because there was no focus on Black moms. But around the nation, we were getting more and more information that Black moms were dying at high rates.
Yeah.
I know in your state, what is it? It was last I checked, and when we saw death by delivery here, we were I'll talk to you a little bit about the other work and how I got into being able to get in the real reproductive health world. Outside of my work with the county. We showed Black Women for Wellness, and I'll tell you about my work with them. But Black Women for Wellness hosted this event and showed death by delivery. And I know New York was one of the states the young lady had in the film, as well as Georgia. And there were very high rates of death, women dying in New York. I'm not sure what your rate is now. I think when she did the show, it was like 11 Black women were dying at 11 to 12 times the rate of white women in New York.
Right. What time? What year was this? Because I also feel like I've heard of this program maybe at APHA, the American Public Health Association.
We presented for APHA. I don't think it was last year. Maybe it was the year before. I have to think about it. Me and my colleague Raina, under our health promotion and deputy director of LA County Public Health is Dr. Allen. So Dr. Allen had us come and present to APHA. And so, but the year, we started this in October of 2018 is when we had the first initial AAIMM, but we were planning into 2017 into 2018. Planning these conversations around what community action teams, because my role formerly as associate director was to either establish a community action team or work with one in place. And the role that I was in was to identify gaps in services and resources, and then work with agencies to figure out how we could collaborate, how they could collaborate with other organizations to make the change and impact the incidence of death or disease or improve health outcomes.
Yeah, right.
So that's just some of what we were doing.
That's a lot. You guys are busy.
We are extremely busy. We're extremely excited. The initiative has taken on a shape. I would say the first CAT was formed, I said, in South LA, South Bay. We've been replicated 3 times by other colleagues and community members in the county. So Antelope Valley also had a high rate of infant mortality. And so they started the second cat like about 6 months, maybe not that long after. And then we have two that have just formed, San Fernando, Santa Clarita Valley, and then one in San Gabriel Valley. So the whole purpose of the community action team is like a public-private partnership to bring community and government together to address a specific health issue. For us, is African American infant and maternal mortality.
Right.
To elevate Black voices, right? To also elevate Black leadership, to bring organizations that have been doing the work that a lot of times the smaller CBOs, nonprofits don't get the funding, but they've been doing excellent work in our communities. They know what to do. Further, to bring community members, actual mothers, fathers, grandparents, anybody in our community, pastors, everyone in our community together to address this issue so that everybody knows here's a problem that we're having.
Yeah.
We have not yet reached the halfway mark in our county. How do we come together collectively to do that? To ensure that we are providing equitable care. The other issue that happened and why we were able to get, I feel like, a lot more traction was that Dr. Ferrer did bring it to LA County that racism was one of the leading causes of infant mortality. As well, across the nation, they were saying the same thing. Racism is one of the leading causes for Black maternal mortality. Mm-hmm. So for me, it was combining both, because you couldn't continue to solve the problem of saving babies without saving the ones who have carried them, who are, who have held them in their womb, who will hold them in their arms and carry them the rest of, the remainder of either the parent or their life. So,
right.
The other thing was that we were very concerned about the fact that CDC reports that we lose approximately 4,000 Black babies annually. And that's critical mass for us. We can't afford to lose 40, right, in my estimation, considering all the other racist related and
right.
issues
right.
So
when you at like some of those stats, like even further, I looked at it like at this point is maybe like 2 years ago, because we have to think about life expectancy, right?
Mm-hmm.
So right. I think what I learned was like there are more male children born than more girls, African Americans. Yet life expectancy of the males are shorter. There's a percentage that die in infancy, and then there's a percentage that die, in the 18 to 24 range. We all know why. And then if you make it past that, there's all the other comorbidities that a lot of melanated people tend to suffer from because it comes to like low socioeconomic status, like not the same amount of education, the same amount of income. So naturally that affects like food sources and how you eat, your housing, and all of those other things. And it just becomes one messy pot that affects life expectancy. So if we're losing them, as infants before we get to a point where we can fix things, that's we're kind of losing them at the source. So it makes we have to think about birth rates being really low and kind of moving our support toward like the support of families and nation. So no,
absolutely. I mean, that is really critical and really for us, one of the things I said from the beginning is that we need to be celebrated just like anybody else in our pregnancy and birthing journey, right? It's always been some stigma almost attached to like, well, is she married? How many children does she have already? She's overweight. All those different things that come out rather than saying, congratulations, like you're pregnant. Oh, wonderful. Okay. How can we support you in the journey? And I found this, I always thought about this when I used to do this work, do the perinatal health education. And I go on the west side of town. And on the west side, they have these gazettes and they have all these mommy and me classes. And, they'd have swimming and everything, yoga, all these different things. And it was like, okay, where is that in our community? It's few and far in between. The other thing is like a lot of victim blaming and shaming of Black women. and Black bodies. And we've had enough of that. One of the things, like when we started too, was to get the team, all who would be participating, because we also have non-Black members of our team and colleagues who have, helped to start community action teams based upon our initiative in the other regions. So some of the work we had to do is we want to educate people so they have an understanding. Racism is not yet over. Please do not equate this to any other situation or any other public health crisis. For us, this is a matter of really, like, mamas and babies are dying routinely in what is natural. This is a natural happening. We were created to procreate, right? To be here and birth and babies and still thrive and survive. And those babies were to thrive and survive, right? But for some reason, it's like, oh no, that's not what's happening. That's not true. But the stories tell otherwise, right? CNN also did an article like last year that, reminded me of that, was that it said Black babies fare better in the care of a Black doctor than they do in the care of a white doctor.
I see that.
And it was like, well, why would that be? Again, it's based upon the color of the skin. Dr. Joy Queer makes a, really poignant point, and she reminds us it's race. This is all race-based issues, right? It has nothing to do with the, a person's humanity over the color of their skin. And why is that so? And so one of the things let me back up a little bit. I was going to say, I had the group, like we were supposed to do this book club and pick books like every couple months. And the one book we picked initially was Killing the Black Body by Dorothy Roberts, because it's critical for us to see that this has been going on for 400 years here in America. And we need to tell the unvarnished truth. John Hope Franklin was an African-American historian that talked about us telling the unvarnished truth, and that truth of what has happened to the descendants of the African slave here in America. And that is it.
So I want to back up a little. First, I want to go over and acknowledge the chat. Greetings, Precious Stephanie. So we'll probably have some questions from people in the chat. Greetings, Sham the Joy, Sovereign Eats, Akuya Bisa, Peace, Sister Kashia, Chief Yuya. I'm so glad all of you can join. And so we'll be looking out for she says she has the book that you just mentioned. She said it's a good read. And Akuya says it's interesting to know that the numbers are still high. She remembers being a mother, a part of the Black Infant Health Project when California launched the pilot program. Maybe it was Akuya that I heard that from, because I have heard about this project. And I'm I'm looking forward to working with my sister girl Akuya, who I met through my siblings, right? So, and she told me, hey, I was, a part of that. I benefited from the Black Infant Health Program I believe in Pasadena for her. And so the county, California has a Black Infant Health Program in various counties across the state. And so that program is designed to address infant and maternal mortality, to stop preterm and low birth weight babies, but to also support, provide support and case management for Black mothers and babies. But I will add too, part of our work too has been to engage fathers so that Black men in our community. I'm glad you said that, because I was going to back up. I'm like, well, because I wanted to back up to the part about, like, when you go to other towns and you see all of these amenities, I don't know how else to say, like these things and these programs in place. A lot of the times they're started by grants of, a lot of the times community-based organizations in those areas, they're working with a better pot of money, right? Because we know that taxpayer dollars and monies get funneled to different zip codes. It really is we talk about this in public health all the time, that, your health shouldn't depend on your zip code, but we know that that's a fact, right? And then the other part is, so when we go to the part of town, when we see our, melanated brothers and sisters struggling, what are the differences, right? And so, like, pulling on the fact that you mentioned fathers, there are, we do know that other communities have, similar situations when it comes to single parenthood and like the struggle, but they're not necessarily, they're not in the same numbers. And so we can see right there that there's a difference between the two. So when we start to look at like, okay, so where do we look to change? What do you think, what are your thoughts on, kind of like accepting and acknowledging like those real truths about how we can reduce some of those issues, because we know that some of it comes from capacity, not having insurance, not having like, the stable kind of family setting or community setting. Community has a lot to do with it. So how do we acknowledge some of those truths, and acknowledge like the lack of presence of fathers and why that is, and et cetera, et cetera.
Listen, one of the things I had to like lean in, one of the things I think is critical for us to realize, and that's why we said we had to tell the unvarnished truth, is that because we had questions, it was like, why Black infant health? Why AAIMM? Why African American? Because we are the ones who are dying at the highest rates, because we are the ones who have been most egregiously impacted in this nation. First of all, in order for us to rectify a problem, we first have to identify what the problem is and then come up with the solutions. The problem is race has everything to do with it. The problem is that we've been blocked out. We have these conversations, and we're even other parts of our initiative, Cherish Futures, for example, deals with the hospital collaborative. So they're working with hospitals. And so we have to go back and tell the history of redlining, redistricting, Black folks being, not offered the same opportunities when it comes to education, not offered the same opportunities when it comes to housing, food security. All of those things are critical. So until we can fix all of those, we can't focus on everyone else, because everyone else doesn't have, yes, they have similar, but they don't have it to the magnitude that we have it. And so it's unfair to, even like when you create anti-racism policies, right? If you're not going to deal with the ones who are still being impacted the most, then how do you get into like, oh, well, we can fix it if we do all? No, we've tried the all approach plenty of times and it has not worked. And so it was supposed to be a different type of approach, still inclusive of all. Last June, right? All the letters that came out after last June, but we haven't really seen that still being manifested for us. So in order for us to first address those, we have to highlight what are all of our issues, because it's a lie to say Black fathers are not involved. That's not true. Not all Black fathers are missing and absent. There are a lot that are present, but then there are times when they have.
Say it again for the people in the back.
There are a lot that are present. Not all Black fathers are missing in action at all, but they've had to have creative job situations because, one, they have not had the opportunity of employment. First of all, let's go back a little bit. Mm-hmm. Going back to post Jim Crow, right, or in the Jim Crow era. Mm-hmm. After slavery, Black folks have always been working. Black folks were working. Then there was a time in the Depression, and then Black folks were laid off. And then you go into that era when, we were introduced to state assistance, right? And with state assistance, let's keep it 1,000. What happened with state assistance? State assistance meant no Black man could be present in that house, right? So you either had to lie, you had to hide them. Claudine, we all saw, most of us saw the movie Claudine, I
didn't, but I know about it. I was introduced to it earlier this year. So, and I did see the scene where the woman is coming in, they're cleaning up, trying to make sure.
Right, trying to hide it. And that causes a whole nother rift too, where we talk about the over-criminalization of Black folks, either through the Child Protective Services, through social services, through the police system. I'm sitting up here in awe over a situation. I just saw Attorney Ben Crump tweeted about 4 elementary Black girls in Tennessee were arrested and charged, elementary, 8 and 9, arrested, handcuffed and everything, and charged for being criminally culpable or liable for observing a fight with some young boys and not doing anything. What, pray tell, were they to do specifically? Right. That would cause, because I've watched NFL games, they've been baseball games and such, where plenty of people have been watching the fight, the melee, right? And who is being charged for that? I mean, it goes all over the nation, the world, where I'm like, so now you're going to do the girls. So our prisoner pipelines. So it's so many situations that we have higher rates of, so we can't get to the point, because actually if we are fixed, the rest end up getting fixed. Give you a prime example. We have a bill that just passed, SB 65. Our governor, Gavin Newsom, signed it, and it's basically similar to the federal omnibus, but it's smaller in such that it has about 9 points, one of which is to provide doula services for Medi-Cal recipients. It does not define just Black women. That means other women will now have the opportunity of doulas. We have done work to show forth that doulas are critical. And we pushed out, like me and 3 other colleagues, we are part of the Women's Policy Institute of the Women's Foundation of California. And we put forth a motion to our board of supervisors, which they adapted and put forth. But what I'm saying to you is that it's not just defined, it was to address and be one of the strategies for reducing AIM, African American infant and maternal mortality. But when you're talking about Medi-Cal, state aid and everything, that's not defined by a specific group. So there's benefit. So we need to stop that, because I have a problem. I feel like we need to create something about inclusive, but yet still exclusive. Like, come on,
This is what I mean. This was like the crux of my question before. Not that we are focusing on everybody else. We know that there are, differences, right? But sometimes we have to look at what they are so we can get to the problem. So now when we let's push everybody else aside, right? And then we look at what is happening to melanated people. What is it that we do to fix our own things? Because clearly we cannot necessarily rely on the outer and, the father government to fix it, because they're not. Like you said, racism, white supremacy, it exists, So these are that are built into the fabric of a lot of things that happen here. So now we have to sit and acknowledge that. How do we fix it on our own?
Right. And I don't know if you want to look to some of the comments in the chat. I know that, so I wanted to just pause for that in case you wanted to add that there, because I see Sister, I don't know if I'm saying it right, but Kashia is dropping in some stuff.
She's a doula, so she's like, yes.
I'm a doula too. Go doula, go. But but I'm more of a doula advocate, because I want to advocate for my doulas, right? And we need to let folks know how important the work of a doula is. And how, the advocacy there, the support that is given, white women, non-Black women have been having doulas for a minute, but actually we were the first of the doulas in this nation. We were the first of the granny midwives. We were the first wet nurses. So it's always interesting to me. And part of this work is just naming and calling out those truths. So one of the things we would do in our community action team was we would have a place of racial grounding at every meeting. And we would go back and tell history. Some of the history is that Black women had to be the wet nurse for their masters and mistresses, right? The slave owners, right? Which meant a lot of times their children were malnourished or starved to death because they first had to, provide breast milk and, put those white babies on their tits and, provide the nourishment at the expense of their own.
Yeah.
You probably get no extra biscuits, no extra, food from the house. And it's so interesting. Like when you talk about racism and how people don't like Black people, and it's like, but these are the ones, we're the foundation. We're the ones why most of you still exist, because it was our great grandmothers, our foremothers and forefathers that did the work. Our foremothers that fed yours, and literally from their breasts. And then also in that kitchen. So that for me as a woman, as a mother, I'm not allowing anybody to care for and nurture and raise my child that I don't like, that I feel is less than human. So the psyche in that, the rationale, I never can grasp, because that is so damn oxymoronic.
Right. So I'm gonna go over to the chat, but I want that question to percolate on the table, because as you're even talking about the doulas, like and the wet nurses, those things still happen today.
Mm-hmm.
Sure about like the feeding part, but I probably are programs where women can give breast milk, but nannies are still alive and well. Au pairs are still alive and well. I'm not sure what the scene looks like in LA, but here in New York, we have many melanated nannies, and melanated, meaning like Black, African American, Caribbean,
Mm-hmm.
Filipino, that people with high amounts of melanin pushing strollers with babies. So that industry is alive and well. It's not, I wouldn't even say that it's a point of like history. It's maybe
Right.
shifted
It
over
still
time,
exists.
but it's
It
still
still
alive
exists.
and well.
Right, absolutely. And we're supportive of that. Like we have one of the first, I won't say, well, in South LA, I know for sure, probably not the only, but right now we have a Black birthing center that Kimberly Durden, who was a doula and now a midwife, along with Allegra Hill, I believe her last name is Hill, opened this Black birthing center for Black women last year during the pandemic. So super excited about that, either last year or early this year. So they're open. We have, Charles Drew is now opening the Black Center of Birthing Excellence, right? So they're going to be working with Black midwives. They're part of our initiative too. Our partner in that. They're going to be working with Black midwives and doulas to provide services in the community, excuse me. And so, Kashia, I like some of the things she's saying. She said, the Black woman and her community must not be attached to others' plights and focus on their own needs without compromise. Absolutely. Absolutely. It is nothing wrong with that, us uplifting that, because we've always sacrificed ourselves for others. And now is a time when we should not have to sacrifice ourselves for the benefit of other people. I mean, if people want to be honest and truthful, the civil rights movement were born off the backs of Black people. And as a result, others have benefited from that movement. And so it is important for us to keep the history relevant, because the reality is we're still suffering as a result of that history. And we're pushing forward for change. And so that for me is exciting in public health, that public health is taking a part of that. I think there are shirts that have gone around. There was a county, I want to say it was Riverside or San Bernardino County, started last year. And I don't know how far it's moved around our nation, but they had made racism a public health issue in their county. And so we know it to still be true. And, if I go back and think about those 4 babies being charged, and I think about the fact that there's an argument about the other officers that stood by and allowed that man to murder George Floyd.
Mm-hmm.
They're under oath and they're adults.
So what do you think? And like I said, I'll go back to the chat. So what do you think? How do we address that from your point of view of maternal and child health, like, and knowing what we know about the doulas and like your experience as a doula? What is something that we can do to address that, like ourselves, like in our own element? How do we address that on our own?
So what I will say this, because I'm more of the advocate, right, for the doula, right? I did that, right? I did perinatal health education, so it wasn't that it was far off from that, but there is a definite focus, around pregnancy, the pre, during, and post. So you even have abortion doulas, you have grief and support doulas, you have the full spectrum doulas. So you have various aspects of doula services that are being offered to women, birthing persons and their families. So for me, I feel like it is to advocate and uplift that role, right? And support that role, and also build what we're doing in public health is bridging the gap of communication, because sometimes there's been challenges with healthcare providers, whether it's the doctor, the OB-GYN, or whether it's the nurses. So we're looking at establishing good communication and relationships, so that I have a good sister colleague, Jada Chatterjee, who started, I want to say Loom, she co-founded or founded, and she's also a nurse, and she's I want to say a OB-GYN nurse, but at any rate, or L&D. one of the things Jada really reminded us of when we did this doula town hall is how she bridged the gap of relationship to, instead of talking about the doulas or, and speaking against them, to like introduce some of her nurse colleagues to the doulas and vis-a-vis build a relationship. So it's not seen as though I'm here to work against you in your role. No, I'm here to advocate for this woman or this birthing person to help them find their voice or use their voice. Because a lot of times, and really for any of us, I tell people all the time, I wouldn't care what your situation is. Don't do your best not to go to the doctor alone. Mm-hmm. I know in this pandemic, that's been a real challenge. So whether you can use your phone so people can hear what you're being told, because sometimes when you're in the midst of that situation, your stress levels are, you're not thinking, even for those of us who are well versed, the things go out of your head. You're thinking like, I'm going to ask all these questions. I'm going to, say this to my doctor. I'm going to say this to the nurse. And you get there and you forgot all of that till you get to the point. You're like, not to, so helping people to navigate the system. Also letting people know you have a voice, you have a right to complain, you have a right to switch your provider, you have a right to ask questions to find out if certain things are medically necessary. I think that has been helpful even in reducing the C-section rate, because what happens is, this is what great study for people that are I want to say document, but it was actually NPR did this study called Lost Mothers. Mm-hmm. And it's great for people to go back and listen and read some of those articles. And in that, it really talks about some of the work that I want to say Nina Martin was her name of ProPublica did with moms, Black moms. And really her story was around Shalon Irving. And Shalon is critical for a lot of this change too, because Shalon Irving worked for CDC. She had several degrees. She had her MPH. I believe she had she had at least 2 masters. I'm not sure if she had a doctorate, but anyway, Shalon died within less than a month of having her baby. And she was a single mom, but now her infant daughter was left to the care of her mother. And Shalon's situation could have been avoided. She had, I believe, preeclampsia, and it was about the misreading, but it was also, she was going constantly back and forth to the provider. And Shalon was one working on the same issues that most of us are working on, improving health outcomes, looking at these comorbidities and looking at the trauma. And as a result of Shalon's situation, her good friend, who was also a nurse at the time, who's now Congresswoman Lauren Underwood, put forth a lot of work around the California Omnibus bill and a lot of other efforts. I mean, not California, I'm sorry, the federal Omnibus bill, a lot of efforts to address maternal mortality and morbidity. So it's critical that we look at it from that aspect of what are some of the issues, right? So for every issue or every problem, there's a solution. Mm-hmm. And then we come up with the solutions, or we provide the solutions that have worked well for us. Or we look at, bringing community members together, bringing moms to the table, bringing doulas to the table, bringing midwives to the table, and there are Black midwives and the granny midwives, and then there's a certified midwife. We shouldn't be getting all crossed up, on this, when our goal is to do what? Make sure that the mom thrives and survives, has a healthy pregnancy, and make sure that baby is born healthy, well, whole, and also has a chance of survival. Because again, like you stated at one point, our infant mortality rate sets, what should be our life expectancy rate. That is what is used to look at the life expectancy of a nation.
Mm-hmm. Right.
Mm-hmm.
Kashia also says like there shouldn't have to be an explanation as to why, if there's a health person, if the health of a person is supposed to be the focus of all who are in the medical. We had a discussion about this on True Health Live, which is our podcast channel. True Health Live, for those of you who are watching, you can check out True Health Live on YouTube or on any of your podcasting stations. And Kashia was one of our guests, and we had a very full and lively discussion about like, you know, her experience, even like with healthcare providers and like their standoffishness when it comes to doulas. And so this is, you know, and again, we're talking about some of those dynamics can be mixed up in, you know, race, everything that's happening. You know, there's the, you're not as educated as me, or, you know, I'm the clinician, you're just this, whatever. I really don't understand what it is. So I'm going to shun you because I'm the doctor and I know whatever, I know everything that I'm supposed to do. You know, regardless of what the patient wants, which is really what we're there for, is to make sure that the patient and the baby, mom and baby survive and are healthy. So it goes to like, how do we, like you mentioned, the Black birthing centers, we create our own birthing centers, or hospitals where we do have more staff that look like the people and the community they serve. I think I heard say today, like, you know, say nothing about us without us, right? So, you know, so I think like, so this was like, kind of like where I was going earlier, is like, you know, have our own things where we're not dependent on outside spaces, so that, because only you know what you need. And if we're reliant on other outside forces to say, well, this is what you need, then we get watered down population that says, look, okay, this is for everybody. When we know that everybody doesn't need it in the same amounts, only certain groups need a certain, you know, certain attention for things.
Well, yeah, and here's the thing: if you're a provider who's really interested in the health and wellness of your clients, then, or your patients, what you're going to do is provide them with that appropriate information and education, right? Because one, providers, you know, if I have a great provider, I tell people about them, right? It's the same thing. And Aquia asked a couple questions. I want to go back to that. Is that there's nothing wrong with asking questions, right? There shouldn't be any dumb questions. So if I'm asking you a question about my care, my body, you should be willing to support that. Here's the thing: is that what I'm finding that is important when I have conversations, I've had conversations with, you know, med students and presenting our work to them, is that if you're taking an oath to provide care, is the oath, I don't know anywhere in the oath that it says based upon the color of the skin.
The Hippocratic oath. Well, right. It is Hippocratic, right? Hypocrite, right?
Well, I mean, listen,
so we gotta
I wasn't going to go into that. Sister, I'm just saying the oath in and of itself, whether it's here, whether it's with police officers, whomever, your oath is to provide a service to a people, to human beings, not based upon the color of anybody's skin. And so that should not be where you're held and bound by. You're held and bound by the condition that they present themselves in at that time, is what I would believe is the where you're held and bound. And so the other thing is we're working with great physicians, those who are not as aware, those who would like to be aware, and those who are very aware. Like we have a partnership and collaborative work with Association of Black Women Physicians in Los Angeles. Aquia said, yes, it's very important to have an advocate in place when speaking to medical professionals. Yes, and that's why we're bringing medical professionals to this conversation and clinicians to the conversation, so that they can hear from those who are receiving the services, and then also those who are receiving the services can hear from the providers. And we bridge the gap where there is some breach, where we need to make a repair. We should be bridging the gap in those conversations. She said, how are you able to gather many mother and father to participate? Because we're talking about we're asking them, what was your experience like? If it wasn't a great experience, how could we improve upon that? How would you like to be involved in it? We are also able to gratefully, when you asked about starting these initiatives, you said something about funding. One of the things I'll tell you is we had no funding for this. Okay. It was based upon my role in the work, and I started asking people. And there was
why wasn't there funding?
There was a 5-year plan. The plan included having some county staff to work on it. The plan also included part of the initiative I was working on, which was a pilot program, was also funding a couple of public health staff to work around our 6 issues of focus. And many of them got involved in this work. I can say my non-Black ally especially my Latinx brothers and sisters that got involved in this work. And there's plenty of, we have some, white ally brothers and sisters too. I don't really like to focus on that, but there are critical points where we do have to, acknowledge the differential in race when it comes to, trying to dumb down an issue or ignore the issue. What we're saying here is this is what is happening. So we were able to bring those folks to the table, and gratefully, public health leaders like Dr. Ferrer, Dr. Allen, and also other departments have assigned their staff to this work because folks are seeing it. Let me not mention one of our greatest partners too. There is First 5 LA. That is partnered with public health to lead out the initiative. The other partner that I can't get away from, there's so many, but like First Kaiser, Health Net, we're looking to establish further partnerships, Blue Shield. There's so many health plans that they came to the conversation. They saw we were having this meeting. The first one we did in October 2018, we're coming up on the third year of doing this. There were over 100 people packing the room. We had to turn people away because the capacity was 100 people. So pre-pandemic, we were in place. Thankfully, through the pandemic, we did a pivot into virtual spaces. So we're able to push out. We have the Black Infants and Families website. You can go to www.blackinfantsandfamilies. Let me make sure. I think that's .org. I'll put it in the chat.
You can get. I can put.
Yeah. And so just getting the conversation going, introducing the work. I was out there pounding the pavement, passing out flyers, sending out, collecting cards, sending out emails, inviting people, and getting, all who could there. I invited a young brother, Henry Solomon, who was doing some work with fatherhood engagement. And he brought to our community action team, one of our first kind of support group offerings was Black Daddy Dialogue. And it's a group created by Black men for Black men. And it's to also educate them about the AAIMM work or, this crisis of African-American infant and maternal mortality. That is now expanded because of there was our great now supervisor, former Senator Holly Mitchell, put forth a bill called Pregnancy and Dignity in Childbirth Act. Most of you guys might know her from the Crown Act, which deals with our hair, right? Us not being discriminated in the workplace or wherever we go based upon our hair, whether we want to braid it, whether we want to afro, however, locked or whatever. Mm-hmm. And so she also put forth, along with Black Women for Wellness, this a bill that would address racism and bias and have required physicians to, and anyone actually who comes in contact with pregnant women to be trained on implicit bias and racism in the professional setting, not via computer like we're doing, but actually in a classroom setting to be able to reenact and dialogue. And also looked at starting to gather the data around maternal deaths so that people know, like if a woman dies within a year of being pregnant or after delivery or after termination, then that data is collected and investigated further so that we have the actual maternal mortality stats. There's more to the bill, but those are some of the things that happen with that bill. And so that really also helped push out a lot of our work. So just the conversation, just telling the truth and just bringing folks to the table and say, hey, would you be interested? Can you share with somebody? That's how he did it.
Right. Greetings, top tier speakers. This is women definitely need more support in terms of education and building a positive mentality that will empower women to give birth confidently. Exactly. I think, this is where some of those community-based organizations, because there's some who maybe they don't have this capacity as a health department or a large institution, but they have their fingers and all their, they got their hands in the community and they can still do great work that is engaging to.
Right.
And they need a little bit of boost when it comes to filling out papers for grants and things like that, and I think that is something that's probably present in many major cities when it comes to, it's like that tale of two cities. It's where all the money is, and then there's every place else. And in every place else, you've got all the community-based organizations. And it's how do the larger organizations, and I work for larger organizations, how do we help them build capacity without becoming that, as we learned in one of our other previous Masters of Health shows, that Goliath organization,
Right. But it was, I would say, March of Dimes, I would say there's so many organizations that got involved in the work from the beginning. They became a part of our planning team. Then we have a countywide steering committee that really brought together Black executive directors of nonprofit organizations, smaller grassroots organizations that have done excellent, powerful work. Like I said, so like my MBA, though I've been in public health for over 20 years, it was really focused on nonprofit management because I was working with organizations doing contract management from the county side and seeing that we needed real support around our organizational capacity, our infrastructure, and how we do business, right? How we do the business of health and how we further engage and ensure that our programs are sustainable. So, we have to look at, and I have some plans probably for more doctoral work, in public health, but nevertheless, my life has been public health, right?
Yeah.
And there's so much room in this public health space for us all to come together over the work and really do like what I'm hearing, seeing some of in the chat is to how we build our own and focus on our own, that it is okay to focus this issue on those that are most impacted, because we're not denying anyone else an opportunity. What we're saying is we are the most impacted. We are in need at this point, and we want to change it. We want our numbers to mirror the ones that are not dying at that rate. We want it to be even better for all. So if we go down, then everyone else should go down too, because we're impacting the service provision. And so CDC, even after this, CDC created last year their Hear Her program. I think it was last year or early this year, Hear Her program, which is designed around hearing women, period, in the perinatal process, the maternal process, that they know their bodies and being sure that you're hearing the concerns and the issues that they're bringing to the table. So we don't have the LaShandra Hazard, who was sitting in a clinic in, I believe, Rhode Island, and who was saying, there's something going on. She was in her 20s, like I think 23 or 24. I'm having this pain in my body, and she was about 3-4 months pregnant, and they kept telling her, "There's nothing wrong. It's nothing wrong with you or your baby." By that evening, her and her fetus had expired. You have the situation of Amber Isaac. The young brother has now created the Rose Foundation as a result of Amber in your area or on the East Coast that said, "Hey, I'm going to share my story after I have this give birth to my baby. I'm going to share my story." And she did not make it. And we have more stories like that, like our brother Charles Johnson, who started Kira for Moms, who really did a lot of advocacy work, who is the son of Judge Hatchett, whose wife died in our city as a result of being, ignored by their provider when she was, when he first saw blood going into her catheter. So we want to keep these things from happening, because what's happening is we're having children who do not have their parents with them. Their moms are not available to them, or we're having parents who are bearing their infant babies and being ignored when they go into the system. We're working on with Black Women for Wellness, which is a nonprofit advocacy organization in my city, who I've worked and volunteered with for over 20 years, because it helped me to, I got into it because my mother was passed away from breast cancer, and I really wanted to look at advocacy for women into early screening and care. And then I got more involved because I was a teen mother. So we had a program called Shangazi, which was like an auntie mentor program for pregnant and parenting young women, similar to what we're talking about with the doula. So this is not new to us. We know how to advocate and support, but we have to learn to support the organizations that are doing the work, lift up their voices, share. And if those organizations are not doing excellence, no different than these providers, then we have to be a voice of concern and say, hey, what's happening here? How can we make some significant changes so that you can do work in excellence, right? And we can thrive better together. And so that, that for me is the critical space of public health is, improving and changing. We're more than our data too. You know what I'm saying? We should not everything should not be subscribing just to data, because data comes out late. And in the midst of that, folks are dying.
Yeah. And yeah, there definitely needs to be more qualitative. I mean, that's data too, but it's more numbers, right?
Yeah, it's not real time, right? It takes some time for us to collect that 4 or 5 years.
Right.
Okay.
And that's what people a lot of times don't understand with research. Research can be ongoing. Like we can get, some studies will be quick, some quick and dirty. Others, they take place over time. And then that's when you have a clearer picture of what's happening. But because those things take time, it's really good to get qualitative information so that we can have like real world input on what's happening. So I think we kind of went through different questions just from our conversation. So give thanks for our conversation. I told you it'll be like organic. Got the questions, but
yeah, no worries.
About your profession and how you gave us a little bit of your career path and like what you do. So I asked this. So we kind of basically went over everything. So I always ask, what advice do you have for aspiring public health students or anyone looking to get into the world of addressing infant mortality and maternal mortality in the African American group, in that grouping? Like what advice would you have for them?
In that particular group or just public health period?
You can do both.
So in that particular group is hear the voices of those that are being impacted. Hear the voices of pregnant moms. Hear the voices of moms who have not been able to carry to term. That you don't get to, I always say, let's be careful in our space to not ignore those women who have not gotten the official title of mother because they never carried to term, but they've had 10 miscarriages. They've had 5, they've had 2, they've had 1. Those women, those voices are critical to the work that we're doing too. They become the aunties, the sisters, the surrogates. They're a part of our network, and they still have a voice and they have a right to participate and be well received and heard. The other is to, don't negate everything that is said because we're talking about race and racism. Don't try to quantify it based upon other people or the experience based upon, how many people experienced that? Listen, if that was the experience, let's take into account all the experiences and look at ways that we can, bring some resolution for folks. I think it's also important to hear the voice of the providers and also work with our healthcare plans to say, listen, you talk about the cost, all the costs associated. And to me, prevention is the best form of reducing many of those costs. When we provide prevention at the, where it is critically needed. I think that's the imperative. We need more partners in this work. If you're looking to volunteer, sometimes, the work comes after volunteering. The work can come in the midst of volunteering. Like if there's something that you're passionate and interested about in this work, then, bring that to the table, bring that to those spaces where folks are working on for this. This is AAIMM, but there's other public health issues where folks are working on where there's research needed. There's, just the outreach and education is needed. Look at what is of interest to you or of concern. If you have some doubts even about what we're doing, then bring those doubts, but bring it, decently and in order. Like we don't want it to be like, not heard, but we want to be able to hear and uplift the concerns and voices of all. We're excited. We have a lot of students and interns that want to get involved and have got involved in this work. There are lots of projects around doulas. There's the expansion of the fatherhood engagement. There's work with hospitals that have not been, some that have been excellent and some that, have room to improve. there's pilot projects that can be offered. And if you think of something that, oh, that would be a good pilot project around AIMM. Infants, infant survival is critical, right? Beyond the first year. We have some folks like Jessica Wade of Mighty Little Giants that has the NICU project. NICU is really critical and important because there are a lot of families that experience, life after the NICU. And then there's some that their babies have become, our angels. So, they need the support and encouragement there, because there's a lot of, you wouldn't believe the stories I hear about bad stuff that's happened with nursing and doctor staff in the NICU. So there's so much work in this space. If you're wanting to go into public health, you can see now, like right with our pandemic, COVID, it's critical to have more leaders in this work, to have more voices. Look at what are the needs around what we're looking at with AIMM is other issues. So we have STIs that are on the rise. So sexually transmitted infections, congenital.
Yeah, I heard that. Another one of she's going to be a guest coming up soon, I think, on the podcast, and she was saying the same thing. That's been her experience here in New York, that where she does a lot of sexually reproductive health work, and she said the same thing, that STIs are on the rise. And I'm like, this is what? Really?
Well, here's the thing. We knew that we said there would be plenty of pandemic babies, right? Because people were like, okay, like the pandemic love was real, but in that we need to have some real pandemic protection beyond the mask on your face, like, come on, let's keep it 1,000. The other thing is then we look at intimate partner and domestic violence. That is really huge. You would think it wouldn't be, but that's really huge amongst pregnant women. Also housing. You talked about, when you mentioned funding, you talked about the other issues. There's all these other issues, but in order for us, like you said, with other communities that, non-Black folks that have, or BIPOC people who have similarities, when we address some of the basic needs of folks, we can then get to the next level needs that they have, like this intervention and prevention. But if a person doesn't have a home, they don't have security, you are wasting your time.
You're in other critical areas. Some of these things, we have to hit the low-hanging fruit. Low-hanging fruit, like what's happening right now. And if I'm in a space where I'm stressed out, I'm not listening to all these other things.
No.
I need what's going to fix what's going on right now.
My problem right now, problem right now is I'm hungry and I need some shelter.
I need some shelter, right? It's the food, clothing, shelter, right?
Right.
Basics. And if you don't address the basics, then everything else is just a wash.
And the basics have, we have had problems with the basics. I know you guys have high rents because we have high rents. So people can't afford that. High rent, low pay. I mean, the scales are not evenly.
Right. There's no balance. Yeah. Okay. So, thank you so much. This was great.
Thank you. Thank you.
So,
thank you to Aquia for introducing us, and thank you for reaching out. And I'm so glad I did it. I'm so glad.
Yes, I put your LinkedIn if people have further questions or want to. Oh
yes, absolutely. And give me time because there's so much that happens. Let me also tell you before I go real quick, the Black Infants and Families page. So you make sure you can follow our work there.
I'll put it that right now, and I'll also put it in the description box. So just read.
Okay, good. blackinfantsandfamilies.org. So check us out. Hit a sister up. Let's collaborate and keep connecting. And thank you for this space. And I'm so glad to see that you're doing this to encourage others to get in the work of public health.
Yeah, of course. Yeah, I don't know. I've just been doing public health since I don't even know. This is the result of wanting to be an OBGYN and being like, nah, maybe I'll try something different. And so here I am, public health baby.
Ditto, wanting to be a pediatrician. And at the time with HIV and AIDS, I was like, no, I don't think I want to do that.
Yeah.
Yeah.
No, maybe something else. All right. Thank you so much, Adjoa Jones, our African-American infant maternal mortality outreach and engagement director at the LA County Department of Public Health. Give thanks for joining us. If there are any questions, like if it's okay, I'll reach out to you if people have specific questions for people who watch the video afterwards. For all of you watching, thank you. Give thanks to everyone in the chat. If you have any, if you want to see someone in the show, DM me. You can email me. I'm always like, cold calling is a problem, as you know. Also, if there's like a topic you want to know about a specific career pattern, just let me know. You can email at deidresully@gmail.com or hit me up in the DM or drop something in the comments. Give thanks, everyone.
Peace. Give thanks, Ashe. Thank you so much, Deidre.
Of course.